appreciate your time today, and I hope um, I hope I'm able to answer some questions and provide some feedback and glean some good information. So I'm looking at a spreadsheet over here, and what I'm going to do is answer questions that people wrote in for. So I've got several different questions here. I'm going to read off and then answer best I can. And then if there's time left, then we'll just open up the floor and answer questions that way too, whether you type it in a chat box or I guess you could even just come on the screen and ask. That's fine too. So let's get going. All right, so first question from Deborah: does your process help with TBI as a result of bacterial infection? And the answer is yes. We've had multiple types of brain injuries that have come into the office, whether it be traumatic, anoxic, hypoxic, infectious induced, etc. And let me tell you, yes, we've seen some quite strange situations. In fact, yesterday I actually started care with someone that the brain injury did actually initiate from sepsis. So the answer is yes, and there's multiple ways that we address it. You know, we are not a facility that treats infection per se, right? So that's not what we're doing. So obviously that needs to be under control and whatnot. But what we do is we can work on establishing positive neuroplasticity. So that's what we're trying to do. We're going to be finding deficits in the brain that happen from all types of things, imbalances, deficits, etc. And we're going to find novel ways, whether it's using reflexive systems, whether it's building muscle tone, stability, coordination, cognitive processing, you name it, whatever's going on. We're going to be finding novel ways to create neuroplastic change, right? And so that's ultimately what we're doing. I will be implementing some new technology here in the near future when we move into a larger space. I have several things coming that would actually perhaps help this infectious situation even more. I'm not going to really go into detail about that. I can't really make claims again about infection or cancer or anything like that, but this product has been shown to really help with those situations. Okay, next question from Jen. Is there anything in particular you would recommend for families who are a few years out from the injury, particularly for those who loved ones are still considering minimally conscious or emerging minimally conscious? So good question. So one thing, number one, what I would say is just know that the brain is always changing. The brain is going to change, you know, day to day, moment to moment, minute to minute. The brain is always changing. The brain never gives up. That's something else I like to say. And when we talk about minimally conscious states, we have to understand several different things. We do need to understand this lovely picture I drew. I didn't want to go through the hassle. I always have problems sharing my screen on Google Meet, and so I just quickly scribbled this down before I jumped on the call. But this is our vagal system. This is coming out of polyvagal theory. That theory was founded by Dr. Stephen Porges. He has books written on it. It's a great thing. We need to understand that the dorsal vagal complex, which develops early in utero, right? So this is one of the first systems to really come on board. It's connected with the fear dive reflex and the fear paralysis reflex. So the dorsal vagal complex, which again is old, it's not myelinated. It is, when it fires, it's going to shut us down. And it does that for several different reasons. A large reason is for energy conservation. So if you think about the situation where a mom has the strength to lift a car off their kid, right? That happens because before that explosion of strength, that explosion of energy happened, there was a shutdown. There had to have been this dorsal vagal fear paralytic response, whether it be momentary or whether it be minutes, whether it be, you know, whatever the period of time is. You'll get that period of shutdown followed by this explosion of energy. That's just how we're designed. So If we are talking about this in the context of brain injury, what will happen is if there's a brain injury that's sustained, and especially if we're talking about a hypoxic or anoxic event, the brain will quickly default into this dorsal vagal mode because it's all about safety and efficiency. So if we can conserve energy, right, then it's going to be very beneficial for the individual to be able to survive. And so what can happen is that we can get stuck in this dorsal vagal complex mode because of several reasons. We have to know that there's this thing up here, this part of the brain called the amygdala. And you've probably heard me reference the amygdala as the asshole amygdala at times. But what the amygdala does is it is all about emotional processing. Okay, so it's going to process our emotions. What it's doing is it's looking for anything that is going to remotely remind it about some type of traumatic event. And it is not conscious, it is subconscious. And I'm talking about anything, a flash of light, a sound, a smell, a feeling, a thought, anything that it can draw a connection to this traumatic event. And when it fires, okay, I've got the pathways in red, okay, it's firing via what are called spiny motor neurons. These are the most dense, most efficient, fastest firing neurons in the brain. And that makes sense if the whole point is to keep us safe, right? We want those pathways to be fast and strong and efficient. So if you have this injury state and you're shut down to conserve energy to be able to survive, right? And then the amygdala is constantly monitoring the environment for anything that's going to remind it. Again, light, sound, smell, anything. And then it's going to go, okay, we still have this situation. I need to continue to keep us safe, continue to shut down, right? Now, what will happen is we want to develop. We want to go from dorsal vagal to sympathetic, right? This is just normal development. What happens is we develop our sympathetic nervous system, and this is all about movement. Our sympathetics say, hey, rather than shutting down, why don't we run or fight? Okay, and so that is our fight or flight response. This is connected to our Moreau reflex, right? So in primitive reflex world, this is where our Moreau comes in. This is our fight or flight. And again, like I said earlier, you should oscillate between this dorsal vagal sympathetic mode, right? That's how we should work. But from a developmental perspective, you have to understand if the end goal is to get to our ventral vagal system, which is where we're social, we can read faces and intonation. We can say, hey, that person's just ugly. They're not really trying to harm me. We can listen to a voice or other sounds and understand that this is actually a safe scenario, etc. If we're going to get to there, we have to actually first go through our sympathetic nervous system because that is what's helping drive our ventral vagal development. So this is how we should work. Now, what will happen is a lot of times if someone is in this minimally conscious state, you'll see these startle reactions still happen, right? There'll be a sound and they'll startle, or that'll drive a seizure response or something like this, right? It's a very common scenario, even if it's minor. That's the Moreau firing, right? So the brain is literally trying to trigger the Moreau because that will then start to turn off the dorsal vagal complex. So the sympathetics will inhibit the dorsal vagal complex, and our ventral vagal system will inhibit our sympathetic tone. So as we develop, we get this what's called sequential degradation, where as we develop these newer, more robust systems, more geared towards social engagement, thriving, and living, we start to shut down those older systems, which are really just geared towards survival. So in injury, we start to degrade, right? We can be stuck in the sympathetic tone. We can be just in fight or flight all the time. We can be irritated, pissed off, frustrated at the world, just angry at everyone. Or we can be in a complete coma, right? And that would be the far spectrum of the dorsal vagal system. And what I'm telling you is we need to develop how the brain is patterned or how we have this blueprint in us. This is the pathway to emerging, right? Because this is how the brain did it to begin with. So when we're walking someone through this, we have to fire the Moreau. The Moreau is connected to all of our sensory systems, the only reflex that is connected to all of our sensory systems, connected to sight, sound, smell. It's the only reflex connected to smell. Vestibular responses, so quick movements, turning the head, that kind of thing. Thoughts, like everything, right? So we're going to find, what's the best way to drive the Moreau? Is it a tactile response? Does touch do it? Does big movements, vestibular movements, do eye movements do it? Do sounds do it, right? So we're going to, and sometimes we have to fire this in 5 different ways. Whatever, right? So whatever's best for that patient, but that's how we start to work with that. At the same time, we want to be stimulating the ventral vagal system, and we do that through this window here. So we have the ventral vagal system, which is composed of cranial nerves 5, 7, 9, 10, and 11. And that's important because we can stimulate these nerves. So we can stimulate the face for 5 and 7. We can do vagus nerve activation. We can do gag reflexes. We can stimulate the trap muscles, right, for the accessory nerve, cranial nerve 11. So we can start to stimulate these areas to integrate the ventral vagal system, because as we fire the Moreau, that is going to increase heart rate. That is going to increase respiration. That is going to cause someone to fight or flight, right? So that is going to naturally do that. So we want to be stimulating the ventral vagal system to be calming that at the same time, right? So that's how we like to walk through that. To complete the story, we need to understand that there's the prefrontal cortex and the vestibular system that are going to gate and give control over the amygdala, right? So these systems will come in and say, hey, amygdala, that was just a sound. Hey, that was just a smell. Calm down, right? So when able, we like to develop strategies to target the prefrontal cortex. Sometimes it'll be a laser strategy. Sometimes it'll be neurofeedback. It really depends, on the person and what we can do. So I know that's a long explanation, but I wanted to walk through that because this is a question I get a lot, and I get it so much that I actually wrote a chapter about this in the book that I wrote. And so we're going through publishing that right now. So I look forward to that, but it's all about brain injury. It's about brain injury recovery, about innovative methods and what's available and whatnot. So I look forward to that coming out. You can, if you're following me on social media, we'll tell you when it's out. So I hope that helped. Okay. Next question. How can I strengthen my child's neck muscles on the left side? Okay. So we need to, again, we need to understand how we're designed to develop, right? So we need to assess, we need to be able to assess how the neck's moving, what kind of voluntary control there is, etc. But if I don't have any other information about this scenario, what I would say is this is a good mechanism or a good situation where a hands pulling reflex. So you have the person, they're on their back, their knees are bent like they're about to do push-ups. You're going to grab their hands, and we want them in a flex position like this. And I'm grabbing through here, this part of the hand, right? So I'm grabbing them like that. Their hands are flexed like that. I'm going to initiate a hands pulling, and what we should see is that kiddo should start to tuck their chin, right? So reflexively, they'll start to pull, they'll tuck the chin, etc. So if we really just see a left-sided issue on the neck muscles, then you might see them, just contract that right side. At that time, what you can do is you can actually turn their body, like tilt their body and spin them down a little bit so that now they're actually having to use the left side of the neck more than the right. So you can actually position the body to help them facilitate that neck strengthening. That would be an example of an active way to do it. You could also lay them on their side and do some type of activity, whether it be visual, have them look at something or whatever, something that grabs your attention, and have them actually pull their head up, to the left side. From a passive, perspective, which is maybe where we would start, I would start with either deep pressure or vibration over the inhibited muscles. So whether it be an SCM muscle, whether it be the scalenes or the deep cervicals, you can start with vibration, deep pressure, like a massage type of thing on the neck. And then I really am a big proponent of using electrical stimulus in order to contract muscles, because in order to really rehab a system, we need to be changing muscle spindles. The muscle spindle is both sensory and motor. It's a big interplay from brain to muscle. Like this is, when we're talking about brain rehab, this journey is a large muscle spindle discussion, because we have to convert muscle spindles, and we have to convert them so that you can have proper muscle tone types. So it's not just about moving a muscle. It's about moving a muscle in the right way with the right tone. So we have concentric muscle tone, which is contract and relax. We have isometric muscle tone, which is contract and hold. And that's going to be a lot of our postural muscles, right? These neck muscles like we're talking about. And then we have eccentric muscle tone, which is this push-pull mechanism, right? So if you get pushed to a side, your eccentric muscle tone kicks over, because one side of the body has to be contracting at the same time as the other, and they have to be working in synergy with one another, right? As you convert from concentric to isometric to eccentric, this has a higher energy demand on that muscle spindle. And so you literally have to develop more efficiency in your mitochondria. So your cells literally have to produce more energy in order to convert. So concentric tone is less energetically taxing. You need more mitochondrial efficiency for isometric. And then same thing has to happen for eccentric. And this is where laser therapy is king, because it targets that energy system in the mitochondria. It helps us with actually producing more mitochondria, with producing more efficient mitochondria. It helps us convert those spindles faster. It helps us get results faster. So we would use laser over the neck muscles. We would use laser over the nervous tissue, the part of the nervous system that's controlling those muscles. But again, we would be contracting those muscles. I would prefer to use microcurrent. We use a Sabo device that is microcurrent, because microcurrent, number one, it's been used for neuro rehab for many, many years, but it's more comfortable. It's more comfortable than something like TENS or biphasic or something like that. Also, TENS is really more geared towards pain, not geared towards rehabbing a muscle spindle per se. That's why I prefer microcurrent as well. Or my absolute favorite is the StimPod, which is the pulsed radio frequency device that we use. This has been proven to actually increase mitochondria in the cells and actually rewire the spinal cord. And now there's studies looking at what it's doing in the brain as well. So several different things there. I hope that helps. Okay, Jamie, what therapies are available to assist with epilepsy? So a lot, seizure activity is interesting, and I never set out to treat seizures, but because of the type of injuries and the types of patients that we were seeing, we're seeing seizures multiple times a day, and I'm talking about pretty severe sometimes. What was cool is that over the years, we just noticed people reporting back that seizures were improving or eliminating, right? Like we've actually had people just completely get rid of seizures that came in, which was awesome. And it's just look, if you have a brain injury and that makes you more susceptible for seizure activity, well, could this seizure activity or abnormal electrical activity in the brain be a result from the brain trying to integrate and develop, right? So it's almost like a short circuiting in the brain. Could that be going on? Well, I would answer yes, I do. Is it like that for everyone? No, there's going to be different mechanisms at play with everyone. And that gets into the question, what therapies are available? Well, number one, we need to be able to examine the brain and know from a functional perspective where these imbalances are. Are there weaknesses? Are there dominance? What's going on? Because typically what we're seeing is in the under-integrated networks, we will see paroxysm. So paroxysm is abnormal electrical activity that precedes seizure activity. And then what we see is, as we're developing those networks, right, whether we're doing primitive reflex work, whether we're doing some type of coactivation strategy, whatever it is, right, as we're developing those networks, you will see some transient seizure spikes. And that's what we've seen, is that some people will report, hey, the seizures kind of spiked up, they're a little different now. And it's been okay. We have not ever seen like a pathological seizure state. So status epilepticus or anything like that. We have not seen that. But the cool thing is as we continue, those seizures then come down, and then, like I said, in some people they've actually gone away. So that would be my first and foremost thing. But we also have to understand that after a brain injury, you have a higher prevalence of a channelopathy, right? And so that basically means you're at a higher risk of developing a neuroautoimmune attack on these ion channels that control the flux of different ions like calcium, potassium, sodium, these types of things. And if that happens, then what can happen is you can start to bring a neuron to threshold with much minimal stimulus, right? So you can start to get this increased firing rate, and it can spike into a seizure, right? So neuroautoimmunity is a big prevailing factor of fallout after brain injury that we see, and we can test for that in various ways. I prefer to use Vibrant Labs NeuroZoomer Plus to look at that and to see if that's something that's being driven there. And there's strategies around that, and it would depend on the findings. It could be anything from, looking further and saying, well, is there a trigger that's, really initiated this? Do we need to look at foods? Do we need to look at mold, mycotoxins, infections, that kind of thing? So we might need to go on a hunt and see if there's a specific trigger, or there could be some type of supplements or something like that that could really make a big difference. So I hope that helps. Laser, I will say, again, going back to this discussion on photobiomodulation and laser, there is a great use case for photobiomodulation with epilepsy and seizure. There's documented instances of how photobiomodulation helps with seizures in the literature. We've seen it clinically time and time again. I would also just note that I highly recommend you work with someone that understands how different wavelengths impact the firing rate of these neurons. And what I mean by that is, as the wavelength gets longer in the laser, the energy per photon measured in electron volts gets lower, right? So if I know I have a case of a severe seizure disorder, epilepsy case, something like this, I'm going to start by using longer wavelengths. And that's one reason why, as I've developed this new laser, that's a big reason why I put this longer wavelength as an option. So 975 nanometers is a longer wavelength. And like I said, it's a lower energy per photon. So it's a great place to start. You're going to have a less likelihood of increasing seizure activity, which can happen if you go straight to a red or a violet. I definitely don't go straight to a violet. It's a much shorter wavelength, much higher energy photon. But you can progress. You can start with infrared. You can progress to red, etc. It's just it's something that we've been able to manage, using lasers for seizures over several years now. Is just something that we've seen. But there is a great use case for photobiomodulation for seizure. Okay. So this is Rachel. Is 5 years post-accident too late? 5 at age of injury, 10 now. No, you're never too late. Never too late. Not only are you not too late, but you're still young. So 10 years old is still very young. So, I guess a good example is even as we work with adults. I had a pretty severe adult brain injury case come in. I don't remember how far after the accident, but it had been years after the accident. And we saw great changes in a short period of time, which if you look at it, it's like, look, this person, I forget how old they were upper 30s, I don't remember, had the injury several years ago. Most people would be like, well, you're not going to see changes, just manage and, whatever. Not the case at all. And they were even doing PT and OT. Like, it's not like they were not doing anything. We started doing our methods. He quickly was able to start doing his hands pulling, his sit-ups. He was able to start propping. He was able to start writing a few things to communicate. Facial tone completely changed. And then what happened after that even surprised me. He was able to actually communicate when he needed to go to the bathroom and be able to actually void his bladder on his own, where he was having to be catheterized, right? He was having a cath, the nurse or the wife was having to cath him every so often to be able to void the bladder. That then resulted in urinary tract infections, that then resulted in additional antibiotic use, that caused gut issues, that caused immune system issues. So just that alone, now that they don't have to cath him, that alone has changed a lot. Number one, it's a big stress, reliever for the care team, not having to do that. Huge stress reliever for the patient, not having to have that done, and then not having to deal with the fallout of the UTI that would develop every month or every other month. So huge changes even in the adult, right? So the answer's never too late. The brain is always trying to change, always trying to grow and develop. Okay, Laura, does hyperbaric have much impact on brain healing after the initial acute phase? We are 7 months post anoxic brain injury. Yes, hyperbaric oxygen is great, especially in the case of any type of anoxic or hypoxic event. I was able to, I've been able to co-manage and work with Dr. Harch quite a bit over these past, 7, 8 years, however long it's been. And what I'll say is, yes, HBOT is fantastic. I think you should pursue it. I think Dr. Harch would be able to speak to this more than I would. But does it help after the initial acute phase? Yes. And the Navy has done most of the research in this area that I'm aware of. But that's also where Dr. Harch has taken the path of trying to find the right dose for the chronic scenario, right? And largely, largely the 1.3 ATA is the pressure that he typically defaults to, but he'll also find a way to try and change that dose as needed. But the thing is, what I've heard him say and what I've seen clinically is that more pressure is not always better, and especially for the chronic scenario. So just because you can go up to 3 ATA doesn't mean you need to. Oftentimes that 1.3 mark on the pressure is really the best. But yes, use it. Yes, it's great. Be monitoring. Be aware that oxygen toxicity can happen, right? So you can develop reactive oxygen species, and this can cause this increase in inflammation, increase in symptomatology, and just be able to monitor and give breaks, and definitely work with Dr. Harch on that if able. Okay. This is Michelle. So if I was able to afford a laser, could I just use the laser and then incorporate the movements at a later time? I'm not able to move our body the way I would need to right now. Yes. So, yes. So just using laser and light therapy and not doing physical rehab will carry benefit. And I'll say that just from reviewing literature, from seeing it clinically. Is it better to do rehab and use laser to magnify the results of rehab? Yes. So my favorite way to use it, right, to use laser therapy is to stimulate brain networks via co-activation. So whether we're doing vibration, electrical stimulus, primitive reflex work, vestibular care, whatever is needed for that patient, we're activating brain networks, and then we're using the laser over those networks to accelerate neuroplastic change. When you use that laser, what you're doing is, yes, you're modulating. You're modulating blood flow, modulating inflammation, but you're increasing growth factors, releasing stem cells. You're doing all these things that are going to help networks grow and form faster and develop into this sustainable change, right? So that's ideal. Is it beneficial to use the laser and not do the rehab? I mean, you're talking to a rehab doc, so it's hard, right? Because I'm a laser guy. I develop lasers, and I use them. I love them. but I'm also a rehab guy. I love physical medicine. That's where I started my career. I'm, so this is a hard question for me. You need both. So maybe the best scenario would be letting us develop a home care for you, right? So we do an intake, we get, what happened. We come up with solutions that you can do at home in order to combine laser use with doing some rehab at home. So that might be the best option. Okay. All right, here's a longer one. So this is Miriam. My 17-year-old son is recovering from a severe TBI. We started a course of photobiomodulation, 20 minutes daily in about 7 days. He started having a number of sensory side effects, including headaches, strange smells, tastes, sounds. I couldn't find anything in the literature about this type of symptoms other than the transient headaches. We stopped the treatment, but I'm wondering if you encountered these kinds of reactions, if there's perhaps a slightly different protocol that should be used. So yes, I've seen that. I'll explain it like this. As you're using any type of therapy, but specifically with laser, what you can see is networks turn on, networks start to calibrate, right? And so I see this a lot in chronic pain syndromes, right? I always tell people, hey, it's even documented in literature as we start to use laser, you might feel some pain, right? So the pain may change. It may go from a throbbing to a burning, from a burning to a throbbing, right? The quality is going to change. The intensity may change. And that's nerves, that's receptors starting to calibrate. They're coming online, they're having to calibrate. So number one is I like change. So I like that things are changing. There's a lot of information in that, right? So what I would say is, I don't know if we developed that plan for you. I would say that if we did, I would request that we do a consult about it so we can get more into the details. Because based on what I just read, I would say, hey, we're seeing changes. We're seeing changes in sensory systems. We're seeing changes in all types of stuff. This may be a situation where we push more into it rather than pulling back. We may actually say, oh, yeah, let's actually do this. Let's do a little more. Let's do a little different, right? Change is typically good, but without more clinical information, it's hard for me to say that. So let me see if I answered all that. Yeah, I think I answered that. Okay, cool. Okay, Shauna, let's see. What improvements can we expect for a child with moderate quad spastic cerebral palsy? We've seen all types of spastic quad CP kiddos, and we've gotten phenomenal results. I mean, results vary, and it's hard because it's based on where the primary injury or the main area that's driving the issue. We've gotten kiddos where they could not walk and they can now, or maybe they couldn't move their legs and they can now, or I'm thinking of a baby. I'm thinking of them right now where they were completely rigid, and now they're able to sit up. They're able to actually tap on a device to communicate. They're able to kick their legs. They're not standing yet, but they're able to sit up and actually move their limbs in those ways. So I've seen huge improvements, just to be honest. So yeah, let's see. Okay, Jose and Ash. So how might you counsel parents of a child with brain injury but still developing infancy in injury who, as a neurologist says, might develop epilepsy at 3 or 4 due to the setting of the brain? Is there anything that their parents can do to assist to possibly prevent such development? Yes, there is stuff. There are things that you can do to prevent developing seizure activity. How would I counsel you? I would say just know that the brain goes through this process post brain injury. And something that we really need to address is called the energy crisis. Again, I wrote a chapter about this in my book, but basically after a brain injury, whether mild or severe, the brain will go into this energy crisis mode. Think about in Texas, when everything freezes over and everyone goes inside, turns up the heat, we start getting the energy grid is too taxed, right? So we start to get these rolling blackouts. That happens in the brain. So you have this injury that creates this high energetic demand, and you start getting these rolling blackouts. If we don't address that, that's step one, right? If we don't address that, that leaves you more prone to seizures. That leaves you more prone to secondary and tertiary injuries in the brain. That leaves you prone for so many other things. But that's number one. How do you address that? I'm telling you, in the research, the way that you address it is photobiomodulation. That's not my opinion. That's not my biased opinion because I made a laser. That's what it says in the research. In fact, one study, I don't remember when it was from, maybe 2012. It was a study done by Harvard. They said photobiomodulation should be the primary modality used for TBI. So, and it was because of that, right? Because of how it modulates and really addresses the energy crisis. That's step one. Beyond that, I would say getting testing done to know if there's neuroautoimmune issues developing. I will say mold and mycotoxin exposure is a big deal post-brain injury. It can really drive a lot of brain inflammation. It can drive a lot of seizure disorders. So testing the environment, I like to use the company gotmold.com. So GOTMOLD.com. You can use that. You can test your home. You can test different rooms. You can test your car. You can test a school, a daycare, whatever. So testing the environment, making sure that there's no mold and mycotoxins growing in there. And then also testing the person. Doing Vibrant Labs has a mold and mycotoxin panel. There's other panels out there, but I like to use Vibrant. And really in general, just focusing on, eating good foods, making sure you have proper gut health, taking your getting your baseline supplementation, which I would consider DHA, which is docosahexaenoic acid. It's a fatty acid from fish oil, but I like to have higher DHA than in most products. I like to use Apex Energetics product called the Brain E DHA. Fatty 15 is actually a phenomenal product that has just hit the market. I'm seeing great results with it. Making sure that you're consuming adequate protein. If you're not, then getting amino acids. A multi-mineral. I prefer CT minerals, a good complex B vitamin. I like B replete or liposomal methylsorb by Numedica. What am I leaving off here? If I left anything, I'm not thinking of it. And I'm really loving the use of methylene blue. Methylene blue is going to support the mitochondria. It's going to help with oxygen and CO2 ratios, and the tissue is going to help your red blood cells deliver oxygen to the tissues even better. I want you to qualify use of methylene blue and anything else I'm talking about with your medical provider, because there are some contraindications to that. And you want someone to be able to help you walk through proper use of that stuff. All right, we're doing good. All right, so Keitha. All right, let's talk about one of my favorite patients to ever come into my practice. All right, so she says, I know the answer to this, but what tools are most beneficial to help decrease drooling? We're doing PT 4 days a week, HBOT 3 days a week, using Resimax and Interex as much as possible throughout the week, and items like this. Seems like drooling is getting worse. Okay, so this goes back to, first of all, thanks for joining us. Miss you guys. Love Kaysen. Hope he's doing well. So this goes back to that discussion of the muscle spindle. So we start by vibrating. We start with the passive care. We start with those things, and that's really more geared towards developing the concentric muscle tone. When we're walking through this, we're using the foundational primitive reflexes in the hands, feet, mouth, spine, and the Moreau to contract those muscles concentrically. So if I'm contracting the face, I have a stimulus, muscle contracts and relax, right? Contract, relax, that's concentric. But then what we need to develop is we need to develop isometric tone. So contract and hold. So for that, one thing you could do is use the Sabo, which is that microcurrent device, And now instead of using program 10, because program 10 is pulsing, right? We use program 14, which is more of a sustained contraction. And we can use program 14 over the masseters to help close the mouth. We can use it over the areas to close that muscle around the mouth, right? To actually contract and hold. So that would be the first thing I would do, right? Now, as you're doing this, right, as those muscles are contracting, we're wanting to now use the laser directly over those facial muscles while they're contracting and holding. So we're giving those muscle spindles more energy so they can convert from concentric to isometric, right? We may need to do the same thing in the oral pharynx. We may need to do the same thing. This is harder to do at home, but that would be my first thing to tell you. If you're still doing the contractions on the tongue, do that before doing all that isometric contraction on the face. But that would be, the best thing, or the things I would say. Just knowing Kaysen's background and everything, I would say do that. Let's move more into a isometric approach where we're contracting. And again, if you're using that Sabo, that little blue, E-stem box, instead of using program 10, switch it to program 14. Put it where the mouth will contract. You can put it where the masseters contract, lift the jaw, right? And then use the laser over those areas. You want to use the cerebellum setting, so it's pulsing at the same the same rate as the physiologic tremor, which is what we want. We want to coordinate muscle contraction with the inferior olive in the brainstem. Okay, cool. Okay, Rocio, how long does it take a brain injury to heal? That's a loaded question. I don't think anyone on the planet can really answer that question, because I've never seen one brain injury that was copy paste another brain injury. They're all so different. And Kaysen said, "What's up, forehead?" Yeah, tell him right back at him. Sorry, he said messaging on the chat box. So that is a very, very open-ended, very difficult answer or question to answer. What I'd say is, again, going back to what I said earlier, the brain will never stop trying to change. It's going to continue. And what we want to do is we want to direct the brain to develop positive neuroplasticity, because it's either going to go in a positive direction or a negative direction, but it's going to go in a direction, right? Okay. Lindsay, so let's see, I lost my sheet here. Let me pull it back up. We're curious about, I guess, the new laser I developed, how different settings are between each one. For example, red light setting for concussion, different wavelength of red light, and vagus nerve, likewise at higher setting as well. So there's various differences. I actually did a AMA call last night about this. This was one of the main questions people were asking, is what is the difference between the new laser I've developed and the laser I've been using previously, which is made by Avant. Several things. Number one, this is going to be easier to use. So we'll actually have programs built in so that it will actually walk you through on the screen or on our app on a phone or iPad, use this setting, place it here, and start a timer, right? So it'll actually walk you through how to use a multi-step, protocol, if you will. So that's a big difference. I'm always developing new presets and new protocols and things that will never stop, but I'm not putting those on the Avant anymore. I'm only putting them on the 528 laser moving forward, just because it's mine and I've developed it. I love this component, so it's very modular. So this module piece is actually highly proprietary to us. We have multiple diffusers. This is where the secret sauce is. So basically, the optical system that we developed here is what allows us to have a higher powered laser than the Avant. So it is higher power, but it's actually safer. So rather than being a class 3B laser, which requires, various things in the clinical setting, it's a class 3R, which when you look at the power differences, is like, what do you mean you're higher power? Well, it comes down to laser beam physics. So we have optical engineers and software engineers, everyone that we've been working with over the past year to be able to develop this more powerful laser beam, but it's actually safer than the Avant. from a laser classification perspective. I also have some other proprietary optics in there. Wavelength will have a similar red, so we'll have a 638 nanometer red. We will have the 808 nanometer, so each of these modules will have 2 different wavelengths. And by the way, as we continue to iterate and develop new wavelengths, rather than having to buy a whole new laser, you just buy the module part. Like right now, we're developing, or we have betas for green and violet, right? And I'm seeing amazing results so far with green. When that hits the market, you won't have to buy a whole new laser. You'll just simply buy the module, put it in the one, if you have the red infrared one, and you're good to go. But I did include this 975 nanometer wavelength, right? So our IRB module will have red and infrared. One of the infrareds will either be the 808, or you can choose to get the 975 one. I love the 975 because number one, there's not another laser on the market that has it that I'm aware of. But it's a nice sweet spot because above 900 nanometers, we really start to have a specific effect on complex 4 of the electron transport chain. And that's where exclusion zone water is produced. Exclusion zone water acts like a battery for our cells. Non-native EMF exposure dries up our exclusion zone water, right? So think of like putting a steak in a microwave, it'll dry it out. This is what's happening to our cells in the environment we live in when we're bombarded with Wi-Fi and all these non-native EMF things. So this starts to really specifically help with that. It's not too long of a wavelength to where we have to worry about tissue heating. So it's kind of in this nice sweet spot. So there's that. We also have this battery that just pops out. And this is important for multiple reasons. First, it allows you to, if your battery's dead, you just pop another one in, you can recharge the other one, whatever. But with the Avant, the most common failure that we had is the fan. So if a fan went out, right, because it's a mechanical moving piece, if the fan went out, the laser stopped working. It wasn't going to work. You had to send it in. With this one, when the fan goes out, we built it into the battery. So you simply just replace the battery. You're not down a laser, right? Oh gosh, I could go on about the differences, but there's a lot. Our neuro solution settings that we have in the Avant will carry over into the 528. But like I said, I'm developing what we're calling programs that will walk you through different use cases, and we'll always be developing those and iterating on those. So a lot more support, a lot more user friendly, more modular, all kinds of stuff. Cool. Okay, so that got me through the spreadsheet, and I saw there were some things coming up on the chat. Let me see. Can you type something in the chat so I can pop it up, bring it open? Thanks. Okay. Okay, so Rocio, so my son has bilateral cochlear implants due to TBI, bacterial meningitis. Can he use a laser due to the implants? Okay, so I have to answer this 2 ways. As a manufacturer of the laser, I have to say we did not advise using the laser over any type of implant, shunt, any kind of medical device, right? That has to be my answer as a manufacturer standpoint. As a clinician, what I'll tell you is that clinically, we have had people use lasers over cochlear implants, and it's been okay. I try not to use them over shunts. And I know you're not talking about a shunt, but we try not to use them over shunts because we've seen flow rates change at times. But as far as cochlear implants, we have used it. We'll typically limit time, so maybe only 2 minutes over the area, so that we don't have to worry about the photoelectric effect, heating any kind of material or anything like that. But yes, we've used them and it has been fine. Okay, this question, Miriam, we're located in the San Francisco Bay Area. Do you have any colleagues out here who do what you do? We don't have anyone on the West Coast. As far as Neuro Solution goes, we've got me in Austin, Kyle's in Lake Charles, and Ryan is in Atlanta, and we're opening Dubai right now, actually. So those are our Neuro Solution areas. I've trained various doctors. I don't know where everyone has landed, so but I don't know of anyone off the top of my head in that area. Okay, Lindsay, how would you address chronic insomnia? We would like to avoid medications. Do you have any suggestions? The first thing to go to here is the circadian biology discussion. I did a 2-part podcast over that. I would highly recommend listening to those. It was based off of the most recent research I could find. It was based off. I mean, it was. I thought I did a good job, but there were some things that we could do there as far as timing of food, timing of light, etc. That has a huge impact into our sleep-wake cycles, and honestly, just our entire circadian biology, which has everything to do with our growth hormone pulses, to fibrosis, to inflammation, to gut health, to all the things. So that's first and foremost. There's little tricks I've learned over the years, and taking a mineral supplement and a B vitamin supplement before bed has seemed to be very effective. And then also eating some kind of good quality, high protein, high fat something before bed as well. The mineral and the B vitamin helps with neurotransmitter production, and then the protein and fat help to stabilize the blood sugar. That has seemed to help quite a few times. Also having a good exposure to heat. So whether using a sauna, taking a really hot bath, taking a really hot shower before bed, also starts that circadian process of going to bed. So let's see, most effective setting wavelength to simulate the diaphragm for development. We found our sun breathes in a very shallow manner. Okay, so when we talk about the diaphragm, we also have to talk about the pelvic floor. So when we think about our core, it's a box, right? So we have the muscles on the front, the sides, the back, the top, and the bottom. And the diaphragm is the top and the pelvic floor is the bottom. So if we have a weak diaphragm, right, up top, we oftentimes have a tight pelvic floor, right? It will typically be just the opposite. Now, could it sometimes be where the diaphragm is weak and the pelvic floor is weak? Could be. Maybe having someone assess it or whatever would be good. But in general, what we need to do is, yes, you can manually do some releasing on the diaphragm. That's something that I learned how to do a long time ago. Our doctors know how. I also like to percuss, so vibration over the rib heads, because the diaphragm will attach to the inside of the rib cage. So vibrating the rib heads is very good. And then doing whatever you can to stimulate deep breaths, right, while you're vibrating. That's a very good approach. And then some type of pelvic floor stimulus, whether the person sits on a half tennis ball or sits on a foam ball, or we'll have people sit on the vibration plate, this kind of stuff. Some kind of pelvic floor stimulus while you're working on the diaphragm. And then laser setting. I'll have to go back and look. I haven't looked in a long time. In our organs settings, we might have a diaphragm setting. I don't remember. But this area, I would probably actually initially use the solfeggio cycle all setting, just because there's so many emotions that are connected here. This is, close to the solar plexus. There's so many things to consider there. From a muscle perspective, if I think about it that way, I would use that cerebellum setting, because that's going to help the muscle spindles fire with the inferior olive. So either of those settings would be good. Let's see. Miriam, my son's severe TBI has a VP shunt on the left side of his head. As a clinician, is he a candidate for photobiomodulating treatment, or does that preclude? No, he's absolutely a candidate, and we work with that every single day. So yes, absolutely not a problem. We see it all the time. We can work with it, absolutely. What's the title of your book, and where can we find it? Good question. Vanessa, do we have a title yet? No? Okay. Don't have a title yet.
Maybe Never Accept Never, but
yeah. And actually, I think that's my next call, is talking with the person that's helping me navigate publishers and doing all of that stuff. So To be determined on published date. Again, we're still looking for publishers. We had Nova. Nova had interest. They wanted to publish the book, but they wanted to publish it as an academic text, and it was going to be like $180 and not available on Amazon. And that's not why I wrote it, right? I wrote it and I didn't write it as a textbook. I wrote it for caregivers and parents and people that have had brain injuries to understand what's going on and to have, actual strategies that they could be doing at home. So we said no to Nova, and we're looking for other publishers. So, all right. So I'll try and answer these two, and then I do have to jump off. So, any thoughts on keto diet on brain recovery after stroke? Yes, keto is good. Obviously, it's been proven effective for seizure disorders. When you go into ketosis, you're producing ketone bodies, and that is the primary fuel source for your brain and your heart. So yes, that's good. However, we have to understand prolonged ketosis makes you very acidic. And I don't want you to become too acidic. So I like to use a keto strategy twofold. Either one, use rotation, right? So do it for a week, 2 weeks, 3 weeks, and come off of it for the equal amount of time. Or use exogenous ketones. So, eat a normal, healthy, balanced diet, but then after you eat, you can actually drink ketone bodies, and it will help to, number one, just fuel the system. It'll give those ketone bodies for your brain. It actually helps you, it actually gets you into ketosis. So that's my preferred method, just to be honest. It's easier to manage, and the person does not become so acidic. Is normal baric oxygen therapy worth pursuing? My son is 3 years old, has severe HIE, 3 years post-injury, trach ventilator dependent, so it doesn't qualify for HBOT. Yes, normal baric oxygen carries the same benefit as HBOT. It just takes longer to produce the results. And that's coming from a conversation I had with Dr. Harch. So the answer is yes, you can do it. She'll be fine. Obviously, consult with a doctor about it and make sure that you're doing it right and for the right periods of time and whatnot. But yes, you could absolutely do that. Okay, good call. All right, so we are 3 minutes past the hour. Thanks everyone for joining. Like I said, we recorded this. I guess it'll be disseminated somehow. So hopefully, I'm sure Rhonda has a plan for that. But so we recorded it. We'll send out the recording. I appreciate you all being on here, and I look forward to seeing you next time. Appreciate it. You have a good day.